So welcome everybody to our fourth webinar, the StrokeEd webinar here in April 2022. I'd like to welcome you all from a range of different countries around the globe. Good morning and good evening. I'll start by acknowledging the traditional owners of the land on which I am at the moment, here in Gosford in the eastern part of Australia, and acknowledge the elders past, present and future. And a few housekeeping things. We will be recording this session and it will be available afterwards on the website under the resources section. There is no handout from today, but you will be able to stop and start the recording afterwards if you want to follow up on anything, including the references. A reminder that we do have a whole range of online workshops for anybody who's not in Australia. But we're also now doing some face-to-face workshops in different states and territories of Australia. So have a look at our website. Welcome to Kate Scrivener, who's one of our team at StrokeEd, who's going to be doing a presentation today that I'm sure will be very interesting. And Kate works at Macquarie University in Sydney and also at Concentric Rehabilitation. So she'll be telling us a little bit about analysis in the session. So I'll pass over to you now, Kate.
Thank you very much, Annie, for that kind introduction. And thank you very much, everyone, for giving up your next hour to be with us talking about one of my most favourite topics, which is movement analysis and making really good intervention decisions for people with neurological conditions. So in the webinar tonight, I'm really going to try and talk through a science-based process of movement analysis and clinical decision making. So how we go about going from observing someone's movement to knowing exactly what we should do in an intervention session to try and help them improve their performance. After we talk about the process in general, we'll look at two more specific examples in the upper limb and in a walking case example. But let's really start with a bit of a framework to what we're going to be talking about tonight and to some of the language that I'll use throughout the presentation. So I hope that many of you will be quite familiar with the ICF model, which you can see on your screen at the moment. I'm a really strong advocate for this model because I think it provides a really good structured way of thinking, and it also allows us to use some common terminology and know what each other's talking about, which is really, really helpful. But if we think about this model, the first thing that I think about is the health condition and what I need to know about the health condition. And in this case, we're using stroke as an example. So I need to understand stroke, I need to understand the prognosis after stroke, and I need to understand the likely effects of a stroke. So what impairments are people likely to experience after a stroke? And that helps me really understand the health condition. But generally, as a physio, which I am, I'm interested at the activity level. Somebody will come to me and say, I would really like to be better at walking, or using my arm, or standing up, or whatever the activity may be. But it's about more than just the activity level. It's about what that means for the person's ability to participate in their life. So why is it that they want to improve their walking? What is that actually going to help achieve for them in their life, in their role, in their family, in whatever aspect it may be? We've also got to go in the reverse direction and really think about, well, why is this person having trouble walking? What are the underlying impairments to their body function and structure that is resulting in difficulty performing the activity or an activity limitation? And what's nice about this model is it also asks us to then think more broadly about the person's environment or the context that they need to perform the activity in, and about their personal factors or things that might influence their ability to improve or change at that activity. And in the presentation tonight, the part that I'm really going to focus on is how we go from the activity backwards to what are the underlying impairments that are contributing and therefore need to be addressed in training. So how do we identify what is going wrong at the activity level and then look to identify the underlying impairments? And when I think about this, I have a very structured way of analysing movement and making clinical decisions. So I really think of this in a step-by-step process. And that's how I've learnt it from a very long time ago and how I've learnt to now teach it, whether it be at university or within clinical practice. And I was recently referred this book, which is called Qualitative Diagnosis of Human Movement. And this is a sports science textbook, and you can see the reference at the bottom, and I'll give you the reference a little bit later on. And what they talk about within this textbook is the process of movement analysis that they believe is necessary within sports science. So if you have an athlete who wants to improve a certain sports skill, it's the process that you go through in order to identify what needs to be improved and how to improve it. And it was a really nice moment for me of two things aligning, of what we do in physiotherapy, aligning very closely to the way they express this within sports science. And so when they express this, they talk about 4 different steps or phases that we need to go through in order to perform this qualitative analysis of movement. And what I've done on this slide is listed their 4 steps and then added the things that I do within each of those steps. So the first step is what they call preparation. And what this really means is that you understand the activity that the person wants to improve or the activity that you're going to need to retrain. And this really comes down to understanding the kinesiology and the biomechanics of that activity, so you can understand what it should look like and what muscles should be working within that particular activity. And we are very, very lucky in neurophysio that for each task, we have a really clear list of important components or things that we would expect to see in the performance of that task. And I'll talk more to this in a little bit. The next step or phase is the observation phase. And this is where we really observe the activity. So we observe the person performing the activity. And what we have to do in this phase is work out which bits of it they've got and they're doing well, and which bits of it they're not performing as we would typically expect to see. And those bits can either be aspects that are missing, things that they're not doing, or it can be what we call adaptive strategies or compensatory strategies. So things that they're doing differently in order to perform the activity, achieve the goal, but they're not as you would expect. And generally, if they're adaptive or compensatory, they're inefficient and they're really perhaps holding the person back from a more effective and efficient performance. The third phase is the evaluation and diagnosis phase. And in this phase, it's where you work out what's causing the person to be having challenges or difficulties at the activity level. So you need to hypothesize about what impairments could be causing them to have difficulty with the activity. Then you actually have to test those impairments to see if the person does or doesn't have them, and make some decisions around what actually does need to be addressed within your intervention plan. And in the last phase, you implement an intervention plan targeting their individual impairments, and then you have regular re-evaluation to see if the person's activity performance is actually changing or improving, or if it's not, a chance to reflect on that too. So we're going to repeat those 4 steps a number of times tonight to just make sure that, that you get it, that they're really ingrained in you. But what I will say is that this process can be quite challenging to learn. And probably the most tricky step, I think, is really having a very solid understanding of each activity and the biomechanics of that activity. And we'll come back to it when we talk to the walking example, but it does take a lot of practice to really understand those biomechanics well and to be able to relate them quickly in real-time clinical practice to the person that you're seeing. Okay, so let's start with preparation and observation. So in the preparation phase, you really need to understand the kinesiology and biomechanics. And as I said, we're very, very lucky, based on the early work of Carr and Shepherd, that they made a list for us of the important components of many everyday activities. So we'll have a look at it in a moment, but it's a really nice quick reference list to think, what do I expect to see when I'm observing that activity? We then need to observe, and you can video, you can observe in real time, whatever you need to do in order to observe well. And then you need to classify your impairments as either missing or adaptive. And this step is really important. It is important because if something is adaptive or compensatory, you have an extra step to do to work out why it's there. What is the person adapting or compensating for? So it's really important that you don't just address that, but you work out what's the underlying reason that they are actually compensating or adapting. In the evaluation and diagnosis phase, it's where we need to work out what are the underlying impairments. And in order to do that, we need to understand what are the potential impairments for this person with this health condition. And so on the screen at the moment is a chart that we use in Macquarie teaching, and it's a chart relating to damage to the brain, so stroke, TBI, CP. And because it's damage up in the brain, you can see that the possible impairments are really, really wide-ranging. Okay, so we need to know what is the health condition and what are the potential impairments that could be present after this health condition. Once we've got a list of potential impairments that could be impacting on the person's movement, we need to refine it down. So what of those impairments are actually present in this person? And to do that, we need to test at the impairment level. So we need to test if they have weakness or not. You know, you might think, well, I can see weakness. I can see if they can't lift their leg or not. But you do need to remember that there are a whole lot of reasons they might not be able to lift their leg. And if you think it's weakness, you then need to go on and refine that hypothesis through testing it. And that's the same for any of the impairments that you might suspect are present. But what happens in real life is it doesn't normally fit or tick one box. And what often happens is people will have multiple impairments that are impacting. So what we also need to consider is how much do each of their impairments link to activity performance? Because some impairments have a very, very tight association with the activity. In other words, you know, you can't perform the activity unless you have adequate strength, for example. So weakness has a very strong relationship with activity performance, because if you're paralyzed and very weak, you cannot perform the activity. Whereas as you start to get stronger, you start to be able to attempt the activity. Loss of coordination is a bit similar in that there is a bit of a clear relationship, whereas other impairments, it's really not as clear. Loss of sensation, for example, varies very heavily between whether it's an upper limb or a lower limb loss. So if the person loses sensation in their upper limb, then it is associated with activity performance. But if it's in the lower limb, then it's not. Whereas with spasticity, there is no relationship with activity performance. So if you know someone's got weakness and loss of sensation in their leg, to me, you should be triggering in your brain, weakness I know is associated with activity performance, and so I must address that impairment. So it just helps you to prioritize intervention between the different impairments. So in summary with that, the really critical impairments that you need to have in order to perform an activity are strength and coordination. And it's pretty obvious that you need to have a certain degree of range of motion. You don't necessarily need to have full range of motion, but you need to have enough to perform the activity. There are many other impairments that could be impacting. It's not to say they're not. It's just about whether you can prioritize those or not. And you really need to be pretty sure that strength, coordination and range are okay if you're going to move on to prioritize the other impairments, perhaps with the exception of sensation in the upper limb where there is a strong link. And then once we've gone through all that and we've got our priority list of impairments, we need to decide how we're going to intervene or what intervention is necessary. And this is where we really need to be evidence-based, and for each impairment or each problem, really think about what do the guidelines or what does the best evidence tell us should be the intervention. And so what's on the slide there is taken straight from the National Stroke Guidelines in Australia. And so it's for each of those impairments, what is the evidence from the stroke guidelines in terms of the intervention that we should be doing. And so we need to think for each of those, if the problem is there, are we doing or providing the evidence-based intervention? But hopefully what you can see from this is really the impairments that movement or activity are dependent upon is strength and coordination. And this is a really nice table to get you just to think about where the person is at in terms of their strength and coordination. Because if they're profoundly weak or paralysed, then it should be pretty obvious that they need to be able to develop more force or improve their strength and maybe do a little bit of coordination. But at the other end of the spectrum, if they're strong, but they have severe loss of coordination, then they need training that addresses their coordination. If you get them stronger, it wouldn't affect their activity performance. So we need to think about where people are at and exactly what balance of training they need. Okay, I'm going to pause and take a breath here for a moment. Annie, are there any questions at this point?
Yeah, we've got a good question from Kath over in New Zealand. She's saying she remembers Carl talking about in his lectures about spasticity and that we can't really have much of an impact. The evidence says we can't have an impact on spasticity. So why bother measuring it? You shouldn't spend time measuring it. So she's asking, should we assess or measure spasticity?
Oh, what a fantastic question. They're onto it in New Zealand. Look, it is honestly a very good question, because if we're not going to do anything about it, why are we measuring it? Exactly to your point. I personally like to know if it's there, because I think it just helps me to talk to the person after stroke and provide them good information about why their limb is the way it is, and advice to other treatments that come along. And probably the thing that happens the most to me in my clinical practice is people will be seeing their doctor simultaneously, and they'll often be getting advice and perhaps treatment from their doctor. And one of the things the doctors like to advise and treat on is spasticity. So I like to be able to give good advice to the person about what management I think may help them. And I think it is important, if we look at the stroke guidelines, to understand that we do have treatments that can decrease spasticity, but from that, we are not expecting to see improvements at the activity level. So as a therapist, I may refer the person on to a treatment to decrease their spasticity if there is a reason to do that. And things that come up quite a lot is that their hand will be in such a position for them that it's really annoying, it's painful, they don't like the look of it. Or, you know, they'll start to tell me that they can't clean their hand in their shower or something like that. So there may be reasons and I'd like to therefore know it's there over time, I guess.
And if you're going to measure spasticity, what measure would you use?
So I would use the Tardieu scale.
Yeah.
Annie, always have and always will, always have taught it. And look, personally, what I do is in my assessment, I would just use the Tardieu scale, ticking off the box of spasticity and also contracture or passive range of motion. Because as I'm sure you know, you move the limb slowly and then you move the limb quickly. So it's just a quick way of doing both if I am worried about range around a particular joint.
Yeah, thanks. And last week's lecture, which Tam Levy delivered, was looking at people participating in a program where they were attending botulinum. Well, everybody was attending a botulinum toxin clinic, so they had they all had some level of spasticity. So people might want to listen to that recording if they haven't already. Second question. How do you usually quantify movement and coordination? Do you use wearable devices or biomechanic measures? What kind of measures do you use?
So in terms of movement at the activity level, I personally am a very low tech. I would use videos and will use my own observation. I have worked with gait labs in the past, and I have seen it work or attempt to work within clinical settings. And I have to say that I think if you go too high tech, you get more information than you can possibly use or apply clinically. So personally, I think it's great and it has its place, but it's probably not in daily clinical practice. I think we can do a very good job of observing and videoing and seeing the person's performance, especially with people after stroke or our typical clients, where often what is going wrong is really quite obvious, and we're bringing it back to what are the important components of the activity. Are they there or not?
Somebody was asking whether the Ranchos Los Amigos scale is being used, and I would say in Australia we don't use that at all, and I don't think in Europe it's used much at all. It tends to be mainly used in America. The most common measures we'd use here would be the motor assessment scale, the action research arm test, and more recently, I think certainly for upper limb, we're using the Fugl-Meyer. Any other lower limb measures, Kate?
The motor assessment scale would be very well used alongside your pretty standard measures like walking speed, walking endurance, and something like a timed up and go.
Somebody's asking, would you classify apraxia as an important impairment?
I think it's definitely a potential impairment for sure. And look, you'll notice that there was one pretty busy slide, but most of them I try and simplify down the potential impairments and keep it as to the absolute critical impairments wherever I possibly can. But I'm sure many of you can think of other impairments that will affect people's ability to move for sure. It's just making sure you've ticked off the critical ones first, and then, being able to identify the other ones is really a mark of a good therapist in neurology too, as you go along.
I'll ask you one more and then I'll let you go on. somebody's talking about perceptual problems, really impacting on somebody's ability to improve their motor performance. So cognitive and perceptual problems can be quite challenging, especially in the acute stage. And this person's asking about verticality issues, somebody who can't stand or sit straight, and what interventions to improve those kind of problems.
Yeah, again, I feel like repeating that last answer in that there are so many problems that can affect movement, and perception of vertical is really one of them, because if you can't understand what is vertical, it's very hard to stay upright and use the correct muscles to keep yourselves upright. So I think the best strategy we have for that is to help someone to relearn or understand what is vertical, and that's by using really strong vertical cues. So, one of the strongest cues that we have in our environment are walls. So I would very commonly have someone sitting right next to the wall. If they're leaning towards the right, have the wall on their left, and try and re-educate them to the fact that they're leaning very heavily and they need to stay next to the wall in order to be upright again. So it's that sequence of retraining to verticality. But I think the important point of that question is that you're identifying it as a potential impairment, you're looking for evidence for it, and then you're looking to intervene to try and improve it. And that's exactly what we're talking about tonight.
Yeah. Okay, thanks, Kate. And on that topic, Carl delivered a lecture last year on the biomechanics of the trunk, and there's quite a lot of video content in there about how to train people who've got sitting balance difficulties, which you might want to refer to. So I'll let you continue on. Just a reminder to anybody, we're not going to unmute people. So if you've raised your hand, please put your message into the Q&A box, and we'll take some more questions later.
Thanks, Annie. So let's look at an example in the upper limb, because I think talking theory is one thing, but let's think about what this actually looks like in reality. So the first thing we need to do is prepare. So if we know we're seeing someone with an upper limb problem, we need to make sure we understand the activities that they want to improve. And this is a table from our Macquarie teaching material that's adapted from one of Karen Shepherd's early textbooks, the Motor Relearning Program. It was written in 1982. I had a look at it again the other week. It's as good now as it was then, in very clearly talking about what I'm talking about tonight, and that's understanding the important components of a task and what needs to be trained, and making sure we train the essential elements of each activity. And so what you can see here is a list of the important components for the different aspects of reaching, grasping, manipulating, and then common adaptive strategies that you'll see. So this should be a visual picture in your mind before you watch the person after stroke or with any other neurological condition. And you can see in this video a very healthy subject reaching. And again, it's just to remind ourselves that we need to create that visual picture of what does reaching and manipulation look like, what are the important aspects that I need to be looking out for, and so I can see when they're not there when I'm working with someone with a health condition. So then we need to observe, and we need to observe the person with a health condition. And in this video, we've got Mr. G, who's had a stroke. And hopefully some of his observations or difficulties are very, very obvious to you. So here's my list when I look at Mr. G after stroke. And based on what the video was depicting, I've focused on the transport phase of his reaching, so transporting his arm in space. And when we look at the transport phase of his reaching, we can see very easily that his shoulder is not flexed as much as it should be, and his elbow is not extended as much as it should be. So he's got decreased shoulder and decreased shoulder flexion and decreased elbow extension. And then we talked before about the fact that we then need to unpack, well, why is this here? You know, it looks like it's hard for him to move his arm. He's got a big adaptive strategy of leaning his trunk forward. But why is that the case? And so here is a breakdown of his impairment test results, and then my reasoning from that about, well, what is the main problem? And so you can see for his decreased shoulder flexion, his manual muscle test in his shoulder flexors is a 2, which means he doesn't have full range movement against gravity. So straight away to me, that says that weakness is a big contributing impairment. You can see that coordination is hard to test because of his weakness, which is a very common clinical problem, but he's got enough passive range of motion. And it's a very similar picture in this case for his elbow extension. So when I look at that in terms of intervention, straight away I say, well, he needs more strength, and he probably needs to start some task-specific or some coordination training. And so here's the intervention plan that I'm suggesting for him. So that he needs strength training around his shoulder and elbow in the key muscles for the reach, and that he needs some modified task training. So I think the task training shown in the video is way too hard for him. You know, we could lower the height of the box or remove the box completely, and we could consider a way of giving him some feedback about his trunk movement. So one of the evidence-based ways to do that would be to use trunk restraint, but it may be as simple as just giving him some feedback to keep his trunk in the back of the chair. And then I just thought I'd show a video of an exercise that I would really like to use with him, or to at least try, which is an exercise that combines shoulder flexion with external rotation by getting him to draw arcs along the wall. And you can see in this setup, the person's in a chair. So again, you would be giving him feedback about his back not leaving the chair or his trunk not moving forward. All right, so that's the procedure in action. Annie, have you got any other comments having a look at that example?
Yeah, there's a couple of questions. Somebody was saying, does this mean that you would only analyse movement qualitatively?
As in, do we not measure quantitatively?
I think that's the implication.
No, not at all. I would always do both. Tonight we're focusing on the qualitative bit or the movement analysis bit, but we also need a measure of performance. We need something that will explain to us whether a person's performance has changed over time. And we know if we rely just on a qualitative approach to that, it has the potential to be biased. So we do need to understand at the activity level or at the activity level that has meaning for the person, is their performance actually changing? Yeah. Very good question. I like it.
Yeah. Somebody was asking, the last video that you showed, what were you actually addressing in that video?
So look, that's really, again, it's a really good question because, you know, Kate loves to put things in clear boxes and be able to say, yep, that's strength, or yep, that's coordination. In that video, it's probably an element of strength and coordination. And it is a really, tonight I will try and keep things really clean and simple, but it is really important to remember that strength and coordination are not completely distinct. There is an area of grey between them for sure, because if you think of strength as the ability to develop force, But you know, there's a lot of elements to that, like how quickly you can develop it, can you maintain it, how do you turn it off? And coordination being about being able to coordinate different muscles together, different joints together, getting the timing right, that you can hopefully start to see that there is grey or overlap between those. And in that exercise, you're looking at making sure the person can use their shoulder flexors and external rotators. So I guess that's an element of strength or developing force, but also use them together, which is an element of coordination. Knowing that within the task, coming into forward flexion, you need to use your flexors and external rotators together to achieve that task.
Another question, just going back to spasticity, and I think this is a really good topic to come backwards and forwards with, because therapists really get caught up in spasticity and yet forget about strength and coordination as being so important. So somebody's saying, as a relatively new graduate, why spasticity has a lower impact on activity compared with coordination, for example. This is somebody who's working with a lady who's got overactivity in their arm and having difficulty with transfers and reaching and grasping. So how do you determine whether spasticity versus coordination is more or less important?
You're on fire tonight, audience. That is a really, really good question. The table that I presented before is really a summary of the evidence that's been done. And this is generally evidence that measures spasticity and measures an activity at the activity level, and then relates the two and sees if there's a relationship between them. And what that kind of research tells us is someone can have very bad spasticity and still perform an activity well. Someone can have no spasticity and you know, not be able to perform the activity at all. So there's no clear relationship in big groups of people between spasticity and activity performance. And to me, what that says to all of us as therapists is we don't want to assume that if someone has spasticity, they won't be able to, it's going to affect the activity level, because that's not what the evidence tells us. Now, in saying that, so we don't want to have any rules about it. In saying that, you need to, what I'm talking to you about tonight is understanding each individual that you work with problems. And what what you may say is that this person I'm working with has very bad spasticity and a problem at the activity level. Now, what I want to challenge you to do is, one, make sure you've measured spasticity well. So is that true spasticity that's velocity dependent as per the Tardieu scale? And two, make sure that there are no other impairments present that are actually having the impact. So you can have spasticity and be very weak. Is it the spasticity or is it the weakness? So sometimes I think because it's visual and dramatic, the spasticity might get the blame, where actually that's, you know, on the top of the fact that the person can't move their arm at all or can't move their arm very much, or other impairments like loss of strength and loss of coordination.
A couple of other questions. Somebody's asking about the pace of movement. Would that come under coordination?
Yeah, so being able to produce the right timing of the movement. In Kate's, what box does this go in? Very structured approach? Yeah, it would. I mean, again, to my point before, you can probably see that there are different elements of that. Being able to develop force, you know, if you can't develop force very well, it might slow your movement down. So it may be affected by weakness. But generally, you know, people being able to perform the movement at the appropriate timing, you would consider that under coordination.
Yeah, in fact, the other part of the question, or the person that asked that, was if somebody's got stiffness and slow in moving when they're reaching, but they've appear to have good strength in their muscles. That gives you more information. What would you say then?
So again, to Kate's, we've got to put it in a box rule. If someone's got stiffness, to me, I want to know, what does that actually mean? Does that mean that they've got resistance to passive movement, which is indicative of soft tissue changes and the potential of a contracture? Or do you mean that they're, or is it observing more rigidity and that they're not coordinating or timing the movement well? So I would want more information about that so I could understand and then address that impairment.
Okay, I might let you continue on and we'll take more questions as we go along. A reminder to a couple of people who've raised their hand that we won't be unmuting people, so please type your questions in the Q&A box.
All right, so we're on to our second and last example. You're nearly there, which is really looking at walking. So if we go through those same steps, the first thing we need to do is prepare. And so we need to understand walking, what are the important components and what are the common adaptive strategies that we may see. And then we need to observe the person walk. So we're going to watch this man walk, who's about 2 years after his stroke in this video. Okay, so you're not alone if you think he's got a lot going on. This was my slide of the things that I saw in his walking. It's a lot. It's probably faster to, go the reverse and pull what he's doing right, not what he's doing wrong. So in the gait cycle or in walking, there are lots of bits to observe and it can be quite difficult. So what I suggest you do, and what I've done in this case, is pull it back to one phase. So the thing that really stood out to me was probably early to mid stance. And so I've pulled out mid stance here as an area to focus on. And when I look at these photos, the typical walker and then this man, it's very obvious to me that his hip is in flexion where it should be more extended. His knee is hyperextended and his ankle is in quite a lot of plantar flexion where it should be in dorsiflexion. So straight away, I think the two big things are in mid stance, his decreased ankle dorsiflexion and his decreased peak hip extension. So they're the two big observations that I've pulled out. And then just like anyone else, we now need to work out, well, what's going on behind those. But let's stop for a second and jump back to preparation, because it is really important that we understand the biomechanics of walking and that we can understand the relative contributions of different muscles and joints at particular phases. So I'm not going to spend a lot of time on this because I could lecture for an hour on this itself. But on the screen here, we have the power at the ankle, and we've got the ankle joint range of motion. And we know that at the mid stance phase of walking, the ankle is going gradually into more dorsiflexion. And the power output is in A1, which is an eccentric power output, which is basically eccentric contraction of the ankle plantar flexors. So we know that around that point, the ankle plantar flexors should be working eccentrically around the ankle. If we look at the EMG at different joints, at different muscle groups, plantar flexors, hip extensors and knee extensors, and we look at that particular point in time, you can see that the EMG or electrical activity in your soleus, which is one of your plantar flexors, is increasing, whereas your hip extensors and knee extensors are coming off, so they're lowering in their activity. And it's really important that we understand this, because if you looked at that picture, you might say, well, his hip's in flexion, it should be an extension, hip extensors are the problem. But if you unpack what we know about biomechanics, the muscles around your ankle are very, very, very important in walking, particularly in that mid to late stance phase of walking. And straight away, I'm thinking, is he strong enough in his ankle plantar flexors? Why is he keeping his shank back behind his foot and not actually moving forward? So we need a really good understanding of what muscle should be working when and how should it be working. And that then helps us with our evaluation and diagnosis. And you can see in this man that he did have pretty significant weakness in his plantar flexors. They're a 1 out of 5. But even more than that, he's got a loss of range of motion at that ankle, and he's basically stuck, or his end of range is 5 degrees of plantar flexion. And, again, it's chicken or the egg. Probably that loss of range is secondary to the fact that his plantar flexors are very weak and that he's been walking like this for some time. But it's still now severely impacting on his walking because he can't actually get to plantar grade at that ankle. He does have some spasticity, and you can see a little bit of clonus in the video. So some of you may have picked up on that. He also has a pretty significant sensory loss. So in the impairment prioritization, I've put the weakness and loss of range as the top or main contributing impairments, but noting that there are other impairments that could be contributing, like loss of sensation, where we've said it's a significant loss, but also knowing that people with a significant loss of sensation in their lower limb can generally walk quite well sometimes. It's not as clearly associated as something like weakness and ankle range. All right, so big table for him, lots going on, but hopefully you can see that we need to simplify it to what are the key things that he needs to work on, which helps us to develop the intervention. So I've gone in the order of the other slide, talking about strength first. I would be thinking about, to strengthen his plantar flexors, perhaps using the sliding tilt table, which is the photo here with the blue around it, and doing a heel raise with a little bit of body weight. I'd also, you can see in that photo, there's electrical stimulation on the calf as they're doing that exercise. So you might also consider the use of electrical stimulation. If we're thinking about the range at his ankle, the one or the most evidence-based intervention that we would have to choose from would be serial casting. So if this was a very important goal for him, and we really felt that we needed to impact on his ankle range, then that may be the strategy that we use first before embarking on the other strategies. And then we might do some modified task-specific training, and that's the other two photos. So in this photo at the top here, the person's got their back against the wall and they're bringing their body forward, so coming into dorsiflexion at the ankle. And in the bottom picture, this man's obviously much better than our guy in the video, much higher level, but he's doing stepping, and his back foot that's not moving is actually on a wedge that's angling downwards. And that's to try and account for trying to take off the effect of the contracture around his ankle, to allow him to practice moving forward at the ankle. This is quite a challenging exercise, and I'm not sure that the man in the video could do it, but he may need to practice with something under his heel in order to allow him to get his shank forward. So that's why I put the photo in today. All right, so there are two examples. And look, I just wanted to finish with this slide because I read something fairly recently that said, well, an evidence-based practitioner, all they do is roll out the evidence-based interventions. And I just want to debunk that a little bit because, you know, I am a very, very proud evidence-based practitioner. I'm always thinking about whether an intervention is the best I could offer and whether it has the evidence behind it. But I'm also a movement scientist, and I also always try and work out in what an individual's problems are and what intervention that individual needs. I don't just go and roll out electrical stimulation for everybody. I do what we talk through tonight and say, what are the person's impairments? What level of weakness are they at? What evidence-based intervention meets their needs? So we absolutely 100% analyse movement and clinically reason within evidence-based practice framework. It's not one or the other. Okay, that's Kate's little harp on. I'll just link you to a number of different resources. If you're interested in task-specific training, then I'll always promote my own train modules. But with Carl, Annie, Simone, we've also developed a couple of clinical reasoning modules with the Stroke Foundation, and the recovery of walking and the reaching one are very, very applicable to everything that we've been talking about tonight. So if you want to practice that, then that would be a good place to have a look. Last questions, and I'll leave the references up on the screen.
Thanks, Kate. We do have a couple of questions before I go back to spasticity. Somebody's asking about motor control, where that fits with coordination and strength. And I know you've been doing some learning yourself with an overseas module on motor control. So maybe you could define motor control and where it fits.
So basically, every time I've said coordination tonight, you could replace that with the word motor control. So that's the same thing, same concept, different terminology. Yeah, I don't know why. Probably in physio in Sydney, we tend to use coordination as the go-to term, but motor control is also very popular. Same concept.
Yeah. There's been a couple of questions that are both really asking the same or related things. It's whether if you address spasticity early on with something like botulinum toxin, then people can get on to learning how to move. And there has been some suggestion in the past that contracture and spasticity might be interrelated. Do you want to address that?
I don't, to my knowledge, we don't have evidence to say that that's the case. You know, you could probably equally say if early on you get, you know, you practice more strength, coordination or motor control activities, could you prevent spasticity from coming on? You know, again, I don't know, but it is an interesting hypothesis. I think I'm interested to hear what you think about it, Annie, but my take-home message is don't get too caught up in it, even if it's early on. Look at what other impairments the person has.
Yeah,
and
I
look,
think so. Yeah, I think that there have been a number of people over the years that I've seen who've had botulinum toxin given probably too early, and it's made muscles weak that were already weak. And that really affected their ability to start using their arm or to continue using their arm in the way that they had already started to get recovery. So I think botulinum as a drug has its place, but I think our job as therapists is to try and get muscles working as early as we can and continue to do that for weeks and months afterwards. And yeah, botulinum toxin can be an adjunct. But yeah, strength, loss of strength, weakness is probably the major problem that we need to address. Somebody else is asking about...
Lovely answer, Annie. And I think what we're trying to say tonight is we need to be really thoughtful about everything we do, and we need to look at an individual's problems or impairments and make good decisions about their intervention. And so if, you know, there is an individual and you really think the thing limiting them is their spasticity, you know, you've just got to have really good thought process behind that. And you brought up a great point then, Annie, which is, you know, if you're going to recommend some intervention to that, what are the potential negative impacts or negative side effects to that, which could be weakness in that muscle group. And you just need to make sure you fully considered that. What my biggest message to everyone listening is just to really be thoughtful, rather than recommending things as rules, I guess, particularly around spasticity when there is really not a clear relationship between that spasticity and the person's activity performance.
Tam Levy's mentioned in the chat there that there are some studies, and she quotes Wissel, Wissel et al., showing that spasticity at 6 weeks is a critical time, and if the modified Ashworth scale is 2 at 6 weeks, that might suggest there could be a risk of it increasing at 4 months. So perhaps you should be looking at it. But yes, I think there are bits and pieces of research which might indicate that, but I think strength is still a more important consideration, and what concerns stroke survivors much more. There are a couple of questions about serial casting. What is serial casting, and what are the alternatives to serial casting for somebody who has a problem with a contracture?
Okay, also very good question. So serial casting is applying a cast to the limb with the joint at maximal or near maximal stretch, and then you reapply that every few days at more and more stretch. So there are some research papers that show by doing that, when you remove the cast at the end of the series, the person will have more range of movement around that joint. The hesitation, or the reason why we don't do that for everybody, is because that pretty soon after that, they will lose their range, or they're shown to lose range again. So the way most of us would conceptualize it is, if range of motion really is the main issue for someone, it can give you a window of having more range, which you would then think you're going to need to do a period of intense active rehab to try and use that range and improve at the activity level. Unfortunately, we really don't have very many alternatives to that. We don't have very good evidence at all for a stretching program. I can talk, what we do, which, I can talk to preventing loss of range as best as we can, but once a contracture is there, very, very difficult unless you go down more invasive routes.
Yeah. Somebody's asking about people in the acute hospital environment in the first week after their stroke. How do you prioritize impairments to focus on? Is it any different?
No, it's really no different. So I've worked acute to rehab. I've researched the first week after stroke, and if you have a look at some of the papers from my PhD where we documented the reps that people did, you can see it going across the spectrum of strength, coordination. I would, when I meet the person after stroke, whatever day it may be after stroke, I'm starting this process. Even if it's looking at them sitting and whether they can sit upright and they can activate their leg and hip while they're sitting, exactly the same process. Do they have strength there? Someone mentioned verticality before. What other impairments are present or are impacting on their ability to move?
Mm-hmm. And I might ask the last question. I apologize to anybody if we've missed your questions, but we want to keep this to an hour. Because we know that people don't watch and listen after an hour, even after half an hour. you work in a practice with therapists. How do you help people to develop these skills?
Oh, that's a really good question, Annie. So the table that I filled in on the screen before, where I said, you know, what did I observe? What were the potential impairments and their test results, etc. We do that as a learning, as a practice, as a reasoning exercise all the time. And I see a few clients, but not that many these days. But I see a lot of clients via video and via worksheets of people, you know, saying to me, here's a video of John, here's his worksheet. So we practice that very, very often and practice that structured way of thinking. So that's one of the major, and then we seek feedback from our seniors. That's one of the major ways we practice it. And again, you know, for those people that haven't grown up as therapists thinking or learning like this, it does take practice. And I think the thing that helped me is having those clear columns or boxes to work through and not letting myself jump, because you can want to jump. You can want to say, oh, I see the person doing this, so I'm going to do this treatment. But it's making sure, particularly as you're learning, that you stop and you go through the process of assessing and understanding their impairments. And the main reason is so you don't miss anything. So you are working out exactly what that person does have, because people surprise you all the time, to be completely honest. And I don't know if this happens to you, Annie, but people you look at and you think, oh, they're going to have, I don't know, you know, they actually end up being a lot stronger than you think they'll be, or actually their coordination is much worse than you originally think it will be when you first start with your first activity. So it is important to be systematic, I would say.
Yeah. I mean, I think that's one of the reasons why we started running a lot of the workshops years ago, Carl and myself, was because people didn't have a structure or a framework for going about analysing and training people with arm problems after stroke. And then the lower limb workshop evolved for the same reason. I think that people were all over the shop. So having a structure does help. And I think our aim is to help new graduates and students to develop that knowledge earlier and not have to wait 10 years or 5 years to get to that point. So thank you. And for anybody who wanted to go back and look at some of the slides and videos, you can do that in the recording. We won't have time to do that tonight. So thanks everybody. And thanks again, Kate, for joining us. And we'll have more lectures later on in the year for you to listen to. Have a look at our workshop options in the on the website under our calendar. And good night to everybody.